Hello, my name is Kevin O'Keefe, and welcome to Beyond the Numbers, where we dive into the stories behind Canadian health information. Speaking of information, according to the World Health Organization, what's the leading cause of disability worldwide? Well, given that you signed up for a webinar on mental health and substance use, I suspect you already know the answer. But still, the numbers are staggering. Mental health and substance use affects 450 million people worldwide, and 1 in 3 Canadians in their lifetime. 1 in 3. And there's another reason that makes today's webinar even more timely. A few hours ago, CIHI released Taking the Pulse, our report on the latest mental health and substance use data in Canada. And standing by, we have a number of folks here to help us understand what the numbers mean and give their thoughts on solutions to this global crisis. But first, a quick shout out to the hundreds of people zooming in from right across Canada today, including Island Health, the Saskatchewan Ministry of Health, Sioux Lookout First Nations Health Authority, Cape Breton University, and the Centre for Addiction and Mental Health. Now, on to a little housekeeping. All webinars in this series are available in both English and French. Pour écouter l'épisode en français, cliquez sur l'icône en forme de globe. Si vous ne le voyez pas, cliquez sur plus. As well, closed captions are available by clicking the Show Caption button at the bottom of your screen. So when you joined today, you were automatically muted, but we really want this webinar to be as interactive as possible. There are a number of ways to do that. First, I have a list of questions that many of you wrote in, and I was just telling the panelists before we came on, the caliber of these questions are amazing. So we have a great group of people here today. I'm going to read some of those questions off during the presentations. You can also type a question. At the bottom of your screen, you'll see a Q&A button. And my colleague from CIHI, Angela, is standing by and will be reading off your questions throughout our discussion. We'd also love to hear directly from you. If you just click the raise hand button at the bottom of your screen, I can unmute you and you can just ask a question live and have a discussion with the panelists. You can ask a question at any time, by the way. And finally, this webinar is being recorded and will be available on the Beyond the Numbers page on cihi.ca, as well as in a follow-up email you'll be getting within a week from today. Before we begin, we acknowledge and respect the land on which CIHI offices are located. In Ottawa, it's the traditional unceded territory of the Algonquin Nation. The Toronto offices is located on the traditional territories of the Wendat, the Anishinaabe Nation, the Haudenosaunee Confederacy, and the treaty lands and territory of the Mississaugas of the Credit. We acknowledge with respect the traditional territory of the Kanien'kehá:ka, where our Montreal office is located. In Victoria, we acknowledge with respect the traditional territory of the Songhees, Esquimalt, and Wasanich peoples, whose historic relationship with the land continue to this day. We recognize these lands are home to many diverse First Nations, Inuit, and Métis peoples, and we embrace the opportunity to work more closely together. Now, everyone can feel free to acknowledge the land you're zooming in from in your own way. Just before you meet our panelists, it would be really helpful for everybody here to get a sense of who's present attending today's webinar. So please, can you take a quick second to answer our poll? What's your experience with mental health and substance use care systems? Are you a patient, a caregiver, a clinician, an administrator, an analyst, or other? Now, I would like each panelist to come forward and briefly introduce themselves and talk a bit about what they'll be sharing in today's webinar. I'll start with you, Cheryl.
Thanks, Kevin. Hi, everyone. I'm Cheryl Chewy. I'm the Director of Health System Analytics at CIHI, and my team developed several of the indicators that are featured in the report released today, and I'm here to share highlights from that report with you in a few moments.
Awesome. And Susan?
Hi, everyone. I'm Susan Pullian. I'm a family caregiver to a parent with concurrent mental and substance use disorders, as well as a PhD candidate at the University of Toronto. And today I'm privileged to share with you some of my experiences with the data and reflections on it.
Terrific. And over to you, Mary.
Hello, everyone. My name is Mary Bartram. I'm here with two hats today. One as the CEO of Redawood Addiction and Family Services, which is a community-based addiction counseling agency, substance use health and addiction counseling agency in Ottawa. And I'm also here as a policy expert in mental health and substance use health and addiction. I'm an adjunct research professor at the School of Public Policy and Administration at Carleton. Thank you.
Excellent. Welcome. And finally, Mario.
Hi, everyone. My name's Mario Capelli. I'm a child psychologist, and I am the senior clinician scientist at the Knowledge Institute on Child and Youth Mental Health and Addictions. It's a Ministry of Health funded program housed at CIHI, which is the Children's Hospital here in Ottawa. And we provide support to our community-based mental health agencies in terms of the work that they're doing.
Terrific. Thank you, guys. As you can see, the caliber of the people we have here today is really exciting. Before we begin, I just want to quickly take a look at our poll results. So 5% of the people attending here are patients, 6% are caregivers, we have 8% are clinicians, 10% administrators, and a whopping 46% of analysts. So no bias here, but as CIHI, we always love to see data people attending our webinars. So that's terrific. And 25% are other. So thank you again for filling out that poll. Cheryl, one of the things that's really interesting about the information you're about to share is that some of it is actually new mental health and substance use indicators that are part of a much broader suite of shared health priority data. So I'll turn it over to you, and if you can tell us what some of the new data shows.
Okay, thanks, Kevin. I'm going to share my screen. As Kevin mentioned, the indicators we're releasing today are part of a commitment that was made in February 2023 by federal, provincial, and territorial governments to work together to improve healthcare for Canadians across a number of shared health priority areas. You can see those listed on the slide. CIHI's role in this is to measure progress and report to Canadians on improvements that are being made as part of this commitment. And so today's focus is on the mental health and substance use indicators that we're releasing today. But there are also a number of other shared health priorities that CIHI releases reports on a regular basis throughout the year. So today's report, Taking the Pulse, Measuring Shared Health Priorities for Canadian Healthcare 2025, focuses on 3 of the shared priority areas. And I'll talk a little bit more about mental health and substance use and some of the highlights from the report. Kevin touched on this earlier, that it's one of the reasons that improving access to high quality mental health and substance use care for Canadians is a shared priority, is because it affects many Canadians. In a given year, it's 1 in 5 who will experience mental health or substance use issues, and that increases to 1 in 3 in their lifetime. And mental health disorders are among the top 5 causes of disability in Canada. Yet what we see in our data is that many Canadians struggle to get the care that they need. And when left untreated, mental health and substance use concerns can not only take a toll on people's mental health, but also their physical health, social participation, economic stability, and even how long they live. So in today's report, we feature results from 4 indicators, 2 of which are new and 2 of which we have updated data for. So we'll look at unmet need for mental health care, wait times for community mental health counseling, youth access to integrated youth services for mental health, substance use, and well-being support, and then physician follow-up after a hospital stay for mental health or substance use. So I'll spend a few moments going through the highlights from each of these indicators. So first, when we look at unmet mental health needs, we found that about 2 in 5 Canadians reported that who have mental health disorders reported not having their needs met. So it's 41% of Canadian adults and 36% of Canadian children and youth. So this is based on national surveys conducted by Statistics Canada. And when we looked at the age breakdowns, unmet needs were highest at 52% for young adults, those aged 18 to 34, and lowest among older adults, age 65 plus, at 21%. So the mental health supports that might be needed could include counseling services, medication support, or other supports, and barriers to accessing these services may include cost, lack of support navigating the system, and stigma. And when we look at provincial breakdowns, we can see on the map on the right that there is some variation across Canada by province and also by age group. So this is a new indicator that we're reporting for the first time. And so this gives us important insight into where there are gaps in access. So here's an indicator looking at the wait time to receive ongoing and scheduled mental health counseling within the community. And so the median wait time, or half of Canadians found that they were able to receive care within a month. When you look at the breakdowns by age and where people live, adults waited a bit longer. The median wait time was 34 days compared to children and youth who had a shorter wait time of 24 days. And people living in urban areas waited longer at 41 days compared to those living in rural areas who waited 25 days. When we looked at the 90th percentile wait time, we found that 1 in 10 people waited 4 months or more for community mental health counseling. And these longer waits may be related to the services that are available in their area, patient or client demand for services, and the capacity of the programs available, as well as the availability of the mental health workforce in that area. So the third indicator, and this is updated data for a second year, is looking at youth access to integrated youth services, which we did see an increase in. And so we know that many mental health and substance use issues start to emerge before the age of 25, which is why adolescence and young adulthood is a critical time for intervention. So integrated youth services, or IYS, is one model of care that provides mental health and substance use health, along with primary care and other social and culturally specific services to youth under one roof. And this was a new indicator that we started reporting on last year, and we've seen that in 1 year there was an increase in the access to IYS services. So it increased from 895 to over 1,000 youth per 100,000 who access these services. This translates into more than 46,000 unique youth who accessed IYS services across Newfoundland and Labrador, Ontario, Manitoba, and British Columbia. And when we look across the country, the number of IYS sites grew from 63 to 101 across 11 provinces and territories over 3 years. And so because this is a relatively new indicator, we are starting with reporting the data that's available, and we're continuing to work with provinces and territories and integrated youth services networks across the country to collect more data. And we're looking forward to reporting more results from more jurisdictions in future years. So the last indicator I'll talk about is physician follow-up after a hospital stay for mental health or substance use. And this is a new indicator we're releasing for the first time. And this looks at those individuals who, due to the severity of their symptoms or their needs, needed to be hospitalized for mental health or substance use disorders. And so on average, we found that 70% of patients who were hospitalized for these reasons saw a physician within 30 days of their discharge. You can see from the map that there's a little bit of variation across the country. We currently have data from 5 provinces, and we were able to also see that follow-up varied across different population groups, depending on sex, age, where people live, and their income level. And so some of these differences could be attributed to the reason for hospitalization. But also one thing we do know is that follow-up care is provided by many mental health professionals and substance use professionals in addition to physicians. And so this indicator currently focuses on physician follow-up care, but we are continuing to work with provinces and territories to collect more information on other providers of follow-up care, which could include nurse practitioners, psychotherapists, social workers, and others. So we look forward to being able to report more data on this in coming years. The purpose of this data is to help build better healthcare systems for Canadians. And we know that improving access to mental health and substance use services is a shared priority for governments across the country and an important area of focus for Canadians. We acknowledge that healthcare systems have many initiatives underway to address access gaps and barriers, some of which may not show up in the data yet because this is only 1 or 2 years of data. So we have highlighted some of those initiatives in our report. And the purpose of this data is really to provide a common foundation for driving system improvement and measuring progress over time. Thank you.
Terrific. And clearly, lots of people are interested in what you had to say because a few hands have already gotten up, and I love seeing raised hands. I'm just going to unmute Robin and go ahead with your question for Cheryl.
I understand that to receive a diagnosis, a patient needs to have seen a clinician, and the data reports only on people with unmet needs with a diagnosis. What about others that are symptomatic or even have documented symptoms but have yet to receive a formal diagnosis?
Yes, so that's a good point. And acknowledging that what the indicator measuring unmet need focuses on is those who already have a diagnosis, which can be a challenge to even obtain. So I can imagine that if the indicator were to be expanded to include those who do not have a diagnosis yet, that the unmet mental health needs could be even higher than what we're reporting. So you could kind of see this indicator as a floor to help us understand, at least for those who do have a diagnosed mental health disorder, where their needs are not being met.
Excellent. And we have another raised hand. So I just unmuted you, Rana. And,
yes, hello.
Go ahead and ask your question to Cheryl.
Thank you. So in terms of the unmet health needs that you reported on, how is it actually measured? Is it a self-reported kind of indicator?
Yes, it is. So the data are from 2 national surveys conducted by Statistics Canada. So it is self-reported unmet needs.
Okay, and the counseling services, what do these include, the community counseling services?
So the community counseling services, we include types of counseling such as cognitive behavioral therapy, brief low-intensity counseling, interpersonal therapy. So there's a number of different types of counseling and therapy services that are included. But I will note that these the indicator measures publicly funded services that are scheduled or booked in advance and that are ongoing. So one thing that is not included in the indicator, and which I know is rolling out across a number of jurisdictions, are services that allow for open access or walk-in sort of access to mental health counseling services. So what we're focusing on is the wait times for those services that need to be booked in advance and that lead to ongoing care.
Thank you.
Thank you.
Terrific. Thank you for all those questions. And speaking of questions, when I was going through the list of questions that people wrote in when they registered, Susan, there was one that was directed specifically to you by Raquel. And she was wondering what types of support could have helped you manage the challenges that you face as a caregiver. And I know you've given that a lot of thought. So I'll let you take it from here, Susan.
Thanks, Kevin. And thanks for the question. And thanks for having me on this panel. It's an important topic, and I'm glad that I can talk to you about it because there's a lot of stigma attached with this topic. But it's really important that we have the discussions, and I will speak to some of the supports that I think are needed for caregivers. So as I mentioned, I'm a family caregiver to an elderly father with co-occurring mental and substance use disorders, also known as concurrent disorders. I'm also studying this as part of my PhD, looking at the experiences and well-being of unpaid caregivers who are caring for people with these disorders. So this is a very meaningful topic for me, and again, appreciate the ability to talk to you about it. I will just share that, walking alongside my father's journey over the past number of years has been very difficult. The analogy to me would be a maze. And every obstacle, every corner where there would be an obstacle really. And, each corner is a different system of health or social care. And when you go down that complex mental and substance use path, it's really hard to know where to go. It's quite a fragmented system. And when you're dealing with repeating crises all the time, it can be very challenging. And I will briefly speak to the supports because we did get some supports, but it didn't always help because of the timeliness of it. I will also say that for those of you that are dealing with concurrent disorders, what I've noticed is there's a lot more fragmentation with the mental health and addiction systems. So, I remember talking to agency staff where I was being told, which issue would you like to deal with today, which is really challenging as somebody going through this to know that both of them couldn't be addressed at once. I wanted to just spend a few minutes to reflect on the data shared today because I thought about a lot of things and I thought, how do I, relate to this data? What are my experiences? And I wanted to share some of them with you. I will say that I'm, both disheartened and hopeful by the data. I'm definitely encouraged that we are talking about mental health and substance use as a shared priority, and that the data is being brought up in conversations. I think that's long overdue. But when I look at the data itself, I think about the individuals and families behind the data and what they're experiencing on a daily basis, myself included. So I wanted to share briefly on 3 indicators and just what it means to me. So the first one around unmet needs, I also had a lot of questions about the definition, but I think overall to see that, 41% of adults in Canada with a mental disorder had an unmet need, I think to me is high, but also probably an underestimate. In my experiences, stigma has always been a major barrier. And so not only with a person dealing with it, but myself as a caregiver, that stigma by association, it's really challenging to even have these discussions. And I think in some of the healthcare organizations I've been in, you can sort of tell that there's that structural stigma happening as well. And so when you kind of collectively add that together, it makes it very challenging to even, be willing to accept that the service or the support. I do remember some dismissive attitudes of healthcare providers along my journey. And for me, when you add in language barriers and cultural differences, it really makes it very challenging and not surprising that there are unmet needs. On a more positive note, I would say the physician follow-up indicator is promising. It's really good to see that over 70% are, talking to their primary care after hospital stay. It's even higher for the senior population. And for myself as a caregiver of an elderly parent, I would say that number doesn't surprise me, but I think a lot of it is because of the support of caregivers like myself and others who are ensuring that follow-up happens. I would say that my father's family physician has and continues to be such an essential member of the care team, and I just wish that it was a little bit more connected along the way in terms of that linkage of primary care to other systems of care. I think that's something where a lot of stress happens in terms of trying to navigate. And then I wanted to just comment finally on the wait times. So for those who are supporting, and I saw there's some caregivers here, when you're supporting someone with mental or substance use disorders, it can be very unpredictable and very difficult to manage a crisis. So if you're waiting for those community supports, it can be very, very stressful. Often you try to manage it yourself, or you rely on, often it's crisis, police or emergency services. I would say that family members, myself included, are highly unprepared for this. I'm not a social worker. I'm not trained in managing these types of situations. And so to the question raised at the beginning, I mean, definitely along the way, I sought support for myself because obviously it impacted my mental health at the same time. Also, there's no guarantee that those counseling services will be received by the person who needs it, which leads to that continued cycle of sort of emergency acute care and so on, and more demands on caregivers. So, despite kind of sharing some of the challenges just at a high level with you, I do want to say, though, I am pretty optimistic, though, especially is that we're having conversations about this data and we're including caregivers in the conversation. And so I hope that it just sparks more of these happening across organizations. I also want to emphasize that, we can't forget the experiences of people behind the numbers, because that's really where things are happening and where the differences need to be made to see the impact. I appreciate being able to share my experiences, and thanks for your time.
Thank you. And I'm glad you're feeling optimistic because I know even I mentioned at the beginning the numbers, and it can get so overwhelming and so discouraging. But as Cheryl mentioned, some of these are baseline. So at least we have to know where we're starting before we can improve. And you also mentioned wait times. And Mary, I know that's a big point for many people, wait times for community-based mental health counseling. And I know another big issue is substance use and how sometimes that can get a little overshadowed by discussions around mental illness. So I'm just curious how you resonated with some of the data that Cheryl presented.
Thanks very much, Kevin. And thank you to CIHI for this invitation. It's great to participate, and it's great to see this initiative continuing to gain momentum and strength over the years since it was launched. So I know there's a lot of hard work in creating these indicators and gathering data that can be quite challenging to access. So kudos to everyone involved on that front. As I mentioned, I bring two hats, and if I can use my policy hat for a moment, just a reminder that these indicators are really, they're not the only mechanism, but they're the primary agreed upon mechanism for accountability for the federal targeted transfers. And they are coming back into the public and policy discourse because the 10-year mental health and home care transfer, which is where these indicators first got going as the accountability mechanism, expires in 2027, and the working together better transfers that started in 2023. Well, those go for 10 years. The action plans that were the first tranche of those bilateral agreements expire in 2026. So, this was discussed at the FPT Ministers of Health meeting, just I think this week or last week. And I also noticed in the federal Liberal platform, there was a mention of the importance of evaluating those transfers. So all of which to say from a policy perspective that this new report that Cheryl shared is really important. It'll be a key reference point in those negotiations of new action plans. And, in a nutshell, when policymakers and also, frankly, Canadians ask, did the transfers have the intended effect? These indicator reports are going to be a place that people look to for answers, be their first port of call. So with that in mind, I think, while there's all kinds of excellent information in what was shared, it'd be really helpful to see an analysis from CIHI of not just these indicators, but their full suite of mental health and substance use health indicators to help answer that question of have we made progress since the first targeted transfers were launched in 2017. It would also be great to see as this initiative builds further momentum, some gaps addressed. So, as Kevin mentioned, substance use, health, and addiction are less prominent in at least these four indicators. There are certainly other addiction and substance use specific indicators in the CIHI indicator bank. So again, it would be nice to see that kind of full picture. The private sector data piece that Cheryl alluded to, I think is really important to try to get at, especially when it comes to, they play a huge role in Canada in particular, private sector services and in the mental health and in the substance use, health, and addiction space. And it'd be great to see that data brought in so that we can understand better the role that the public versus private sector are playing in bringing down wait times for access and also relatedly unmet need. And the other point I want to make briefly is just that it would also be great to see mental health and substance use, health, and addiction embedded in the other pillars of this indicator framework. So HHR, health information, and primary care are also critical for closing gaps in, and Susan alluded to this as well, in mental health and substance use, health, and addiction. From a community agency perspective, if I can just wear that hat for a moment, while we're not really visible because community addiction services is not part of this release so much, the findings resonate that wait times in our agency can be long. Turnover is high. We're making progress in bringing down wait times, but it's a challenge in the current environment. And I do believe, though, that while you can't see a direct line from these transfers through to the indicators and the action plans that the provinces included in their bilateral agreements and what happens at the level of a community agency, I do see that pathway. Like, I do believe strongly that there's good evidence that there is a direct line. So whether that's things like investments in primary care, which we've been able to participate in getting a small piece of here in Ontario, or the work that the Centre of Excellence in Ontario for Mental Health and Addiction is doing to strengthen health information in the mental health and addiction sector. I strongly believe these things have been facilitated and enabled and amplified by the transfers, and that this indicator work can play a critical role in ensuring the evolution of targeted federal spending in the mental health and addiction sector going forward, that does make and will make a difference at the community level. Thank you.
Thank you so much for that, Mary, and I appreciate your multiple hats and how you're able to look at this from so many different angles. I will mention that Mary and everyone will be back right after the presentations are finished for a very open Q&A. So if you did get a chance to ask your question, all the panelists will be back. But Rami, you have been very patiently waiting to ask a question. So I'm going to unmute you now and go ahead and ask your question.
Thank you so much for the invite, and thanks for this. And Susan, thanks for sharing your experience. So, speaking of hats, I wear two hats professionally. I am a pharmacist for 27 years, and I'm also a psychotherapist in the last 2 years. So I have so much passion toward mental health because of also personal experience. And I can say from what I heard so far, that's fantastic course from CIHI, and I'm just exploring more how the access of care can be very, very productive more and more through having actually access of care through community pharmacy in the proper way. Now, we are all ruled by legislations, so I can't really, of course, I can't diagnose as a psychotherapist even. But I have lots of stories that I'm not going to share now, of course, but that can tell you how really it affected. Like there was like 5 cases at least where I can see in the last year a diagnosis for a couple of ADHD, a diagnosis for a delusional patient. One was actually hallucinating, and that was schizophrenic, and all of them were referred to the doctor by a conversation. And I can tell you that scale is so unused that you cannot, like, it's the perspective of finding the community pharmacy. And the other thing I want to amplify on is Susan's point. They always speak about the patient, but they don't speak about the caregivers. And this is a huge missing puzzle. And I get it. We focus a lot on the patient. We don't understand what's going on around either it's an Alzheimer's disease, which is definitely a neurological disorder, but it does affect psychologically everybody around the patient, or it's really like dealing with an ADHD, handling some substance use that is affiliated with other issues, compared. So I just want to reach out and say I live in Hamilton and I work in Hamilton, and I'm willing also anytime CIHI needs to have some more conversation or details of this role. I'm open to share lots of the things I can share with. Thank you very much, folks.
Thank you for that. And I guess it brings up another a concept of the community pharmacy, and I know there have been lots of discussions around that in terms of, is there a way to plug that into the system? I don't know, Mary, if you have any thoughts on using that as another opportunity to, I guess, remove barriers.
Absolutely. I think there's potential there. Certainly pharmacists play an incredibly critical role in substance use health services already. So, it would be great to see that data also captured. And again, that speaks to both the health workforce side of the indicators, but also, that there's room to build on this as we get a more nuanced picture of all of the various parts of the system.
Terrific. And yes, CIHI does monitor health workforce very closely, and we'll be coming out in the near future with some more reports touching on that. But I really want to get quickly to Mario, who's been standing by patiently. As a psychologist working with children and families, I'd love to know your thoughts on the data and more about your experience working this as a clinician in this space.
Right.
Thank you, Kevin, and thank you to CIHI for hosting this webinar and for your work on these mental health and substance use care indicators. And certainly, I'm really, really pleased to share this virtual stage with Cheryl, Mary, and Susan. So I think the indicators clearly shine a bright line on the challenges that we continue to face in our efforts to better meet the mental health and substance care needs of our clients. And what I really want to focus on is our younger population of children, youth, and young adults and their families, and some of the barriers, gaps, and possible solutions. So the number that really sticks out in my mind is that 52% of young adults have unmet needs. So not as a surprise, at least to me and probably to most of you folks. And so firstly, we know that young people are the most financially vulnerable. They have accessing non-publicly funded programs is out of the reach for most. They've either aged out of their parents' extended health care plans or don't have extended health care plans because of their own employment status. We've known that when young adults are lost, they typically are lost to follow-up when they age out of the child and youth services. So they have this huge gap, and then they don't re-engage services until there's a crisis. And so in part because of that aging out of services and our recognition during the last year, there's been probably in the last 10 years or so, there's been lots of work on developing youth hubs or these integrated youth services where young people, between the ages of the early teens and mid-20s are able to go for ongoing non-fragmented care. And so, through the early efforts of government and even some of the private foundations, and so some of the early private funders like the Graham Beck Foundation or the Donna Green Foundation at Stella's Place and others, these integrated youth service hubs have become an important source of care for our young people. And as the indicators have shown, this has been a really positive outcome. So let's shine a bright light on that. And over the last number of years, the number of these centers, have really grown, and the number of young people that are accessing these centers, again, have significantly increased. Great news, but more needs to be done. So I'll just give you, from an Ontario perspective where I am, in the last 10 years, we saw the number of these integrated youth centers grow from the original 10 to 32. So it's tripled in the last few years. However, Ontario has 52 cities and 444 municipalities. Ottawa has a population of over 1 million and doesn't have an integrated youth center. So while the indicator is trending in the right direction, clearly we need more of these centers, and the need is significant. But in the child and youth space, while these centers are important, they really do only represent a small piece of the solution. And there's many of us who have been working on creating what we call integrated care pathways in this area as an additional care model. And these can be effective if they're created and implemented using the best evidence and thoughtful and meaningful engagement to parents and young people. And these integrated pathways, they can help determine the level of needs by supporting the levels of needs and support by matching the right care to meet those needs in a timely manner. And I just, and again, to reiterate some of the points that were made earlier, the integrated care pathways also need to include the breadth of providers and the various agencies, including primary care, hospital, and community-based agencies. And then one of the other really important pieces of the integrated care pathways, and again, it touches on the indicator, is that the pathway have to be circular, not linear. So in other words, we want to ensure that, for example, physicians and primary care providers can follow up when their patients are discharged from hospital or community-based programs. Well, we're going to do that by having a proper feedback loop. And the pathway that completes the circle of care is one that informs everyone. And we see the challenges from between hospitals and physician follow-up in that indicator. But we know it's even worse when we're looking at discharge from community-based agencies and primary care. Now, interestingly, we have the technology. So, for example, we have e-referral, like the Oceans platform. We have great electronic health records like Epic and MyChart that can support integrated care pathways and therefore be part of the overall solution to supporting care and reducing disconnections of care. Just a couple more thoughts. I want to say a few words about the barriers to services, particularly when we're looking at navigational systems. So I think it's particularly challenging for parents and young people to access services because the services are scattered, between schools, community agency, hospital services, primary care, private health care. But for parents, it's not only a struggle in trying to access services for care, it's a tremendous challenge for them to access, care for assessments. So including, assessments for autism, intellectual learning disabilities. We also forget about the mental health needs of our really young children, those under the age of 6. Our own data at the Knowledge Institute and some of the folks we're working with shows that the number of families in the under 6 continues to grow at a rate significantly higher than we're seeing in some of the other age groups. However, if we really want to support our families and young people in their search for services, we need more than just simply improving navigational services. We need navigational services that help to coordinate service, ideally through a single point of access. In the Ottawa region, for example, with young people, we have one called One Click as its navigation coordinated access services. And there are other communities have similar programs, such as Help Ahead in Toronto. So One Call, One Click helps connect families and young people to mental health and substance care in the Ottawa, Eastern Ontario region, not just for hospital, but also hospitals and community-based services. So it's a single point of entry where you're capturing the breadth of services. The intake workers, based on their clinical interview, use evidence-based screeners. They help identify the level of need, help identify the best service to meet those needs, whether it's in the community or in the hospital, and then monitor the intake referral until that intake initial service contact is made. And now we have 4 years of data that we've been collecting that clearly demonstrate that model helps reduce barriers and improves access across the spectrum of care. Now, wouldn't it be great if every community had a similar program? Having said all this, at the end of the day, the wait times are significant and they truly are unacceptable, and more is still necessary. Thank you.
Thank you, Mary. It's so great to have someone in the trenches who could help explain the reality of some of the numbers that CIHI data. So I really appreciate that. And I just quickly want to go to Angela, who's been monitoring our chat. And I think you have a specific question for Mario, Angela.
I do. Thanks, Kevin. So Mario, what role does a family doctor play in helping navigate mental health services? And does a lack of access to family doctors contribute to the unmet needs?
So I think, some of the evidence shows that over 50% of parents will try to access, mental health care through their family physicians. And there's lots of evidence that shows that, lots of studies that have indicated that. And 50% is probably at the lower level. So the starting point is, your family physician is, is super important to accessing services. Now, often family physicians don't know where to send, their patients to or their clients to. So that's why you need to have, those really good coordinated points of service. That's why we talked about the One Call, One Click. So any physician, maybe a new clinician to your community will know how to best direct, services, to meet that child's needs. I was listening to Remy's question about the role of pharmacists, right? And I think this is a really important, point. And it's really important, again, maybe I always see things through the lens of a young person. I apologize to Susan, the others, and Mary, who work with the older folks in our community. But, I just have, a real narrow focus. If you don't have a family physician, how hard is it to treat disorders that can be easily managed with medication? So let's take ADHD. If you don't have a family physician that can prescribe a stimulant or non-stimulant-based treatment, you're already setting the child, at a huge disadvantage. not to mention that there's still going to be behavioral, interventions, environmental interventions, but you're eliminating a major effective treatment for ADHD. So the idea that we need to think about, how can young people access treatments where we lack primary care, and until there's primary care providers and physicians available, wouldn't it be great to have people like our physicians, our pharmacists being able to prescribe medications that aren't, that would be, easy to administer and can be followed. So just the thought.
Lots of creative solutions, which is terrific. I'm just going to ask Kyla, who is our CIHI person working behind the scenes, if they could bring all of our panelists back on screen. So we have about 15 minutes for kind of an open Q&A discussion. You can target a question at a specific panelist or just in general, and one of the panelists can jump in and answer it. But Angela, I think you have a couple more questions there. So we'll let you go through your list of questions from the Q&A.
Thanks. So this one's for Cheryl. So some indicators suggest that the territories have some of the worst mental health and substance use outcomes in Canada, yet they're continued to be left out of many national data collection initiatives. Are you aware of any plans for StatsCan to improve data collection in the territories to allow for a truly national picture?
Thanks for the question. My understanding is that there are some challenges with getting sufficient sample size in the territories. And so what StatsCan often does with their national surveys in order to get sufficient numbers of responses in the territories is to pool years of data. So we're looking for it to be able to report territorial results in a future reporting cycle. So it won't be as frequent as our annual reporting on the provinces, but that's definitely an area that we are trying to expand the data coverage wherever we can.
And Rami's ears are burning because you referred to him. So Rami, go ahead.
Thank you. Thank you so much. I'm glad I jumped on. Thank you, sir.
Yeah.
And thanks, everybody. So, speaking of Indigenous people, I just want to, that's how much collaboration you need. I had a patient who was off reserve Indigenous, and he was released from the hospital. This was a few months back. And what happened is, from the jail. What happened is he had to have the monitor. He can't move outside the house. And it took them 6 weeks to release that. So we have to keep, I took the decision to keep renewing his substance use disorder medications, because otherwise he can't leave the house to get even medical attention. That's how bad this was by law. This is the judge order. And that's how crazy, sorry for the word, I saw it. The guy lost his brother for substance. His mom has only him, and I know the family for a couple of years, and I couldn't even think or sleep at night how I cannot do this for him. I'm not bragging about it. I'm just saying I had to do something over, because the doctors need to see him outside the system, and he has to go to do his urine tests, and all the stuff needed. And in these 6 weeks, he wasn't covered. Gladly, after 6 months now, he's totally in remission and he's doing great. And I think one of the greatest things about the story is I challenged the law by writing a huge mail with whatever email and send it to the mother and make sure that she sends it to the lawyer. But it took 6 weeks to release that order. And I was astonished that this can happen here. I was like, not even for medical care. That's how crazy it was, with all respect to everybody. So the model, as Mario says also, we cannot work without a total stakeholder think tanks, people who come and bring up where these stories come up from and where the successes that happen. I'm sure Mario had a zillion story. I'm sure Mary has it, Cheryl, Susan, by being a caregiver. Susan mentioned her family physician. Honestly, with the stupid, I'm sorry for this word, with the way how we are paid and reimbursement in the government, which focus purely on volume, not value, we are skipping, and lots of patients are actually falling in the cracks because nobody wants to see them because it takes an hour, and they will get $37 for that. So I know we can't fix everything, but we cannot also keep a blind eye on the major issues that is controlling all of this. I'm sorry for the time, but I appreciate
Not
you
at
guys.
all.
Thank you so much.
Yeah, thank you so much for all that insight. It's really, we should have had you on as a panelist. But you did raise one thing about crime, and someone else wrote in, and I'm not sure if any of our panelists can mention this, but someone said, what are the strategies, programs implemented to reduce the negative outcome of crime related to mental health? Any takers? And Mario mentioned the patient had a monitor on his ankle and he couldn't leave the house. Any thoughts around that, folks?
Yeah, I'm not sure this is quite on point with the question, but I'll just, I guess, first off, mention that people living with mental health disorders are more likely to be the victim of crime than perpetrators. I think that's important to state. And, access to community counseling and attachment to primary care in the communities and having your needs met related to mental health and substance use, health, and addiction. I mean, these are the things that are critical from a prevention perspective. So all of the indicators and the stuff that happens in the community system can be considered as a critical prevention strategy, not just for involvement in the criminal justice system, but hospitalization and other forms of complex social supports and institutions in that. So I just would stress those things in response to the broad theme of the question. Thank you.
Thank you. Thank you so much. If we don't have any other takers, I had a couple other questions that people wrote in when they registered. And I think, I'm not sure if it was you or not who mentioned it, but someone asked about the state of mental health among the elderly. And I know, Cheryl, you did have some age breakdown in your stats, but is there anything specifically around mental health and elderly?
So I think when we, for the indicators, what we try to do is provide as many breakdowns as possible by age, sex, where people live. So I think there's sort of the intersectionality of those different factors. But what we do see is it's interesting that there are differences for those who are older adults in terms of their mental health needs. And then maybe Susan could speak to this a bit more, but in some of the other data that we release as part of the report, we do see that older adults tend to have better attachment or more likely to have a regular healthcare provider. So it's when you kind of start to look at the data together, it's trying to peel back the layers to understand kind of what's happening there. And it could be, in some cases, like Susan mentioned, concurrent disorders or other physical health conditions that then make the situation a bit more complex.
Yeah, certain Susan, taking care of your elderly father. Any thoughts on what your experience was like?
Yeah, just briefly. I mean, definitely, I think it's something, a lot of, somebody mentioned earlier on about having the diagnosis. I would say that this, the diagnosis opened doors, but this is something that's been going on since before, he became a senior. So, you think about the accumulation of all of the kind of issues that keep compounding and getting more complex as you get older, and you add an aging factor. I would say on the positive, like I said, the family physician has seen everything. So through loss, through widowhood, all that stuff, which compounds any existing mental disorders. They're kind of there to kind of witness all that, and then to work again with those who have a family caregiver to say, like, we're noticing all this. And so I think that is where we have had the privilege of having kind of say, okay, we get it, we see something. But I think when I hear Mario, I would really love for it to, prevent, to be addressed earlier on. Like I think about all those youth who are going down this trajectory, and how can we sort of mitigate that before you get to the point of seniors' mental health.
And Angela, I understand you have another question in the Q&A. Go ahead.
This one's for Mario. Building on the point about the challenges families face in navigating multiple entry points across hospitals, schools, and community services. The person is wondering how assessment itself might become the foundation for integration. What strategies or policy mechanisms could position assessment as a coordinated point of access that connects developmental, mental health, and educational pathways?
That's a great question. I think, I always try to find the lowest hanging fruit. Where can we start? And I think assessments is probably a really good place to start. And it doesn't matter, what age we're looking at, whether we're looking at our seniors going through, their challenges, or our young kids, entering school or in school. So I think that, even if we were to say, well, why can't we start with, building, better assessment within our within those points of access? Why can't that even also be an indicator? So it's not just service, but also, knowing what it is and, what are the specific challenges that these young people or folks are going to be facing. So I think it's a low hanging fruit. I think it'll help, it's their first step towards creating a treatment plan, but at least parents and families will have feel like there's a start to where to go next, right? Susan, if I could just add one little comment about your what you mentioned earlier about earlier start. I think that we know that 70% of adult-based disorders begin in early adolescence, right? So that's a big number, and if that kids aren't getting those services earlier on, guess what happens, right? We see them piling up over time. We see them showing up at Mary's front office there at her place and in other, places where, because we didn't provide that, the early identification, the early assessments, the early interventions. Surprise, surprise. We've been talking about this since the first day I graduated school, and here we are, and we still talk about it.
Early intervention. Great solution. And I just have to wrap up, folks. We're out of time, unfortunately. It was such a great discussion. I wish we could continue it. Of course, I want to thank everybody who came out today, especially those who asked questions. Great discussion from our panelists as well. As I mentioned at the beginning of today's webinar, the data discussed here is now available today in Taking the Pulse, which is at CIHI.ca, CIHI.ca. Today, we also released a podcast where host Avis Favreau discusses some of the findings from this report in depth. That's available on most streaming platforms, and I'll also include the link in the email that I sent out. We'll be sending out later on today. Or later on this week, rather. That email will also have a link for some feedback. We welcome feedback to any of our webinars. Easiest way to reach us is at beyondthenumbers@cihi.ca. The email that you'll be getting within a week will also have a survey about today's webinar. Please take a minute to fill it out. We'll include links to resources that our panelists discuss here, a recording of today's webinar, and a link for our next registration for our next webinar. We will be back on Thursday, November 27th, to discuss Canada's billion-dollar health budget. And I know we talked a little about funding in our discussion today, which affects all levels of healthcare. It'll be on the heels of our latest federal budget, so you can find out how healthcare spending stacks up. Are we getting the funds that we need? How will local hospitals and family practices be impacted? And of course, your chance to ask any questions you may have. We hope you'll join us and see you on November 27th.